About Charlie. So it's been said that a general practitioner is a person who knows less and less about more and more, until eventually he knows nothing about everything. Also, that a specialist is a person who knows more and more about less and less, so eventually he knows everything about nothing. It's quite common to find people who are able to combine these styles of learning and knows nothing about anything. Every so often, though, we find someone who manages to combine both these styles to know an awful lot about an awful lot. A general specialist. Will you please give a warm welcome to veteran acupuncturist, scientist, herbalist, educator, wise head, Charlie Bass.
Right. I'm going to make this work. How do I make this work, Nick? Thank you for having me. Before I begin, I'd just like to say what a joy it is to be here at the conference. We're amongst friends again. It's one of the great things about coming here together is that we can come out of our lonely clinics and actually kind of party with each other and circulate with each other. And that's one of the great things about coming here, because we all feel amongst friends and colleagues. So the theme for the conference is widening horizons from ancient medicine to modern practice. And when I was asked to make a contribution to the conference, I wondered what I could talk about. And it suddenly occurred to me that actually there's a narrative that I've had through my career that I'd like to talk about, which kind of follows this theme somewhat. And that is a thread I've had through my practice that has questioned actually what we do. I suddenly realized at one point, what makes us think that we can take a medicine from the other side of the world, from the Han Dynasty, and practice it on Surrey bank managers? Whatever made us imagine that we could take this ancient medicine and just import it wholesale and do it on people in the modern world? So I wondered just how much of it was actually wrong. Now, I don't want to be talking too academically today. I want to really present this as a sort of personal narrative of my own practice, so there's hopefully a few jokes along the way. But when we're students, we kind of accept facts as facts. It's the best way to pass exams, is by just seeing, learning all the stuff, and then going out into the world and practicing it. So I did that, and then I got into practice, and I can remember having a patient quite early on who had clearly got a spleen qi deficiency and some dampness. So Chinese medicine told me that she would have a bad appetite. Almost certainly she would have a bad appetite. So I asked her about her appetite, and she said, fine, how's your appetite, Sandra? Oh, it's fine. And then over the next few weeks, I've got her on the couch to myself, horizontal, and I said, just talking about your appetite issue, what do you have for breakfast? Oh, no, I don't really feel like breakfast when I get up in the morning. But, okay, what about lunch? An apple and a digestive biscuit. And then in the evening, well, by the time I've cooked and I've come home from work, I just have a nibble, really. And this is a person who's told me that she's got a good appetite. In China, people would be dying. People would be saying, I'm dying because I've got no appetite. So actually, I spotted an early cultural difference. And then I tried all these other questions from Chinese medicine. Do you have a stuffy chest? How many patients have we seen who've said, yes, I've got a stuffy chest? It just doesn't happen, really. At least for me, it didn't happen. Even questions like, do you have a weak back and knees? I say that to a Chinese person in a Chinese hospital, and they go, yes, I got weak back and knees. But our patients don't have that dialogue, in a sense. They understand things in different ways. And so it goes on. I was really disappointed, because my training taught me that a patient with significant blood deficiency would be dizzy. Are you dizzy? No, you must be. Honestly, the rules tell me that you are dizzy, and actually, they're not. And so it goes on. Running piglets. Then, of course, I went to China, And it's almost like everybody had been reading Giovanni. You know, you ask these questions, you ask the same questions. How's your appetite, Mrs. Liu? Oh, how? Sanwa mi fan. I ate 3 bowls of rice. And they can actually quantify it. They're really plugged into it. And they understand how to behave. And we go, do you have a stuffy chest? Yes, I do. Stuffy chest. Well, your mum. Sorry, I shouldn't do the Chinese accent. Excuse me for that. Do you have a bitter taste in your mouth? How many of our patients have got bitter tastes in the mouth? I was really disappointed about that. Yes, true. So in China, it all sort of works. So, you know, what do our patients... Yes, my wee is the colour of freshly sprouted mung beans. Honestly, they say things like this. Like running piglets running up my tummy. Yeah, okay. So this is the problem, really. I wondered how much of the stuff that we learn is wrong. It may not have been wrong originally, but how much of the Chinese medicine that we learn just is not instantly transferable to our patient load, to a Surrey bank manager. How many of our truths are not actually true? And this includes perhaps some general theory of Chinese medicine and also the question of symptomatology as well. So I'm going to kind of cover both these things. Take kidney jing, for example. You know, we all learn that as a common kidney pattern, and we somehow, in our heads, maybe translate it into, maybe that's the same as genetic deficiencies or mutations or whatever. Well, okay, we've got the Hugh Hefner problem, you know? This bastard is 80 years old on this photograph. He should have died at 50 with all his teeth falling out and with all his hair falling out. You know, what is Jing deficiency? What's going on here? Why isn't this man following the rules? So we've got this. That's interesting. Nothing happening. We've got the problem of what has been called truth decay. And this is the tendency of the truths in any particular field tending to have a half-life, tending to actually die out over time. And this was known even years ago. So William Osler, father of modern medicine, who was working around the turn of the 20th century, beginning of the end of the 19th century, and he famously used to say to his medical students, by the time you are in practice, 50% of what we've taught you in medical school will be proven wrong. But at the moment, we can't tell you which half. And that was his famous kind of medical. And this is just as true now. And more recently, people have actually started to do research in science to work out the half-life of truths in different fields of science. And they found, for example, in hepatology, the study of liver disease, that truth in the field of hepatology has got a 45-year half-life. In 45 years, half the beliefs and the truths of hepatology are proven wrong. But in other fields, it's much faster. In stem cell research, the half-life is something like 7.5 years. So half the stuff can be rubbished away. Now, we're doing a medicine that is 2,200 years old. What's the half-life of the truths in what we do? Personally, I think they're slower than in science. I think they are slower in science. But we do have this problem of truth decay. In the mid-1980s, I went to study with a chap who was my hero at the time and remained a hero for a long time, which was Ted Kapchuk. And I was really delighted to find that he was a lot cleverer than me, and he was a lot further on in thinking about these things. So he'd thought about it a lot. So he kind of gave me catch-up quite a little bit. It allowed me to catch up on this whole idea. And what Ted Kapchuk used to say at the time was that our patients are different to Chinese people. He was saying, his particular hobby horse was that we had Freud come along and tell us, to teach us how to reflect on our inner life, on our inner sense. So if you say to the average Westerner, how are you? Most of us will go, how do I feel? And we turn inward and we reflect on, am I happy? Am I sad? Am I frustrated? You know, am I whatever, tired? And we're measuring all these internal truths. Whereas his view was that traditionally and in Chinese culture, we were more. It was much more. People would somatize more. They would experience things as physical things in their bodies a lot more. So I thought that was really interesting. That we can we can see that difference between West and East. I don't think it's by any means the only difference. Obviously, the Chinese are changing. This was, for me, the turning point when Chinese people started to copy us and to psychologify, somewhere around 1988. And I love that headline. I saved it all the way from 1988. Chinese queue up to have their heads examined for a change, but they didn't used to. Okay. So today I'm going to talk really about three issues, about three ways that we can suffer truth decay in Chinese medicine, or that we can have things go wrong. One of those is the issue of the historical changes, that things change through time. It's not really that things are mistaken, it's just that the illnesses we have at different points in history change, the background to the medicine practice. There's also the problem of linguistics, that we've got translational issues in making sense of Chinese medicine and doing it on Westerners. So that too can interfere with truth, and also perceptions of illness, the cross-cultural issues about the way that our culture, the way that the experience of health and ill health can be culturally dependent. Okay. So these are some Han Dynasty warriors having tea in a tea house in Nanjing, terracotta warriors. Basically, if we look back at history, if we look back through the 2,500 years of Chinese medicine history, we find that the commonest... Oh, can't quite hear that. That's a sneeze. One of the biggest medical concerns through history was the question of epidemics. You know, sometimes there would be regular epidemics that would wipe out 50, 70, 90% of the entire population. And this was obviously a major concern. Plagues, basically. You sneeze, and then your nose runs, you sweat, and then you have to dig a hole and bury the person. And this was a major thing that we just don't really have today anymore. And of course, the diseases that we have inform the theory of the medicine. It tells us how to practice the medicine, and the medicine comes out of the diseases that are being seen. It was very popular, a very popular health supplement amongst the higher echelons of Chinese society historically contained mercury. So most of a significant number of the top rulers of the country were being poisoned by their health care givers with mercury supplements. And funnily enough, those not funny really for the people being poisoned, but the symptoms of mercury poisoning are your teeth fall out, you lose your mental capacity, your hair falls out, and then you die, and you get sweats as well. So all the symptoms of Jing deficiency actually correspond to mercury poisoning. So why have we got that in our textbooks? Why does it say Jing deficiency, your hair falls out, your teeth fall out? No, it should say mercury poisoning, your hair falls out, your teeth fall out. We could go on, I could actually talk all day about this, but I won't, you'll be pleased to hear. Another epidemic in China, of course, was schistosomiasis, in which, one form of which, little corkscrew-shaped bastards swim up your tackle if you're a man, and set up home and cause inflammation, chronic inflammation and scarring, and also spermatorrhea, involuntary loss of semen. So again, our textbooks, for almost all the kidney patterns say kidney yin deficiency, kidney Jing deficiency, spermatorrhea. We just don't get patients with that. We don't, or very, very rarely. Actually, I did get a patient with this, and this is how I worked this out. About 10 years ago, I had a patient called Mohammed coming for fertility issues, and I asked him his sperm count, and he said 5. And I said 5 million. He said, no, 5. He was naming them individually. And actually it turned out, through an interpreter, that he was also losing sperm, ejaculating involuntarily, and couldn't really have sexual relations with his wife at all, even with his 5 sperm count. And that's when so then it suddenly dawned on me, schistosomiasis. And this was what was the clue for me doing this, was I said, where were you brought up? Oh, on the banks of the Nile. And I knew that the Nile was a schistosomiasis zone, infected river. And so I said to her, when you were a child, did you get schistosomiasis? Yes. So for me, spermatorrhea is primarily a symptom of the fact that historically, epidemically, there was schistosomiasis causing involuntary ejaculation. So we can kind of 90% cross that off our textbooks, in my view. And the same goes for lots of other things. Beriberi was endemic, which would cause leg swelling and what have you. Can we really take the theory that was intended for edema of the legs from beriberi and then transfer it onto our patients who've got heart failure or whatever? Dysentery was rife, goiter, cholera, so TB, of course. TB, where you get night sweats and then gradually waste away and die. But most of our patients don't have TB. So our medicine has been informed by it's been designed around people on the other side of the planet having diseases that our patients don't have. So we've got to reflect on this, I think. We've got to think about this and what it means for our practice. Translation, again, I could probably do a whole seminar just on the translational issues, but I'll just kind of breeze over this for trying to keep on time. Some of the terms that appear in our textbooks are wrongly translated, and one really, or on the other hand, are simply untranslatable, as we know. We don't have words for qi in the English language. We don't have a word for yin or yang. So some terms are untranslatable. Last year, Volker Scheider did a nice presentation on the problem of you, which everybody translates as depression, but actually doesn't mean depression at all. All the textbooks will say you syndrome, and everybody translates that as depression when it doesn't mean that. It means stagnation. And you can have a stomach depression or a stomach and spleen depression with no emotional symptoms at all. One of my favourites is stuffiness in the chest, or mun in Chinese, which is a picture of the heart kind of trapped between two gates. And this is translated usually as stuffiness in the chest, but that's not what it means. It actually means a whole range of things. It means an emotional sense. It means stultifying, being bored. It means feeling oppressed. It's a whole panoply of symptoms that single character means to a Chinese person, but which our patients don't. And so a Chinese person will experience a certain emotional state and verbalize it with the word mun, with the character mun. So we've got a translation issue. There's another translation issue, apart from just translating single terms. There's the issue of the way that the language informs the thinking. That the Chinese people love a continuum. You know, Chinese people like to think, rather than picking out single things, they like to give each end of a continuum to consider. The word for things, the Chinese word for things is dongxi, which means east-west, actually. It means it's two possibilities there. When the Chinese double character term for everything is qiandi, heaven and earth, meaning everything between heaven and earth. So we've got all these terms. Duo xiao, if you go into a shop and buy something in China, you say, how much is that? Duo xiao qian, little, much. So a lot of Chinese expressions are actually in terms of a continuum of possibilities. And we tend not to do that so much in English. We tend to just pick particular spots, particular places on that continuum. So this one, the average Chinese person probably wouldn't know, but in Chinese there's the expression "kesuo," which means which means coughing and expectoration. Now, if you can sometimes take a patient in the West and you can say, "Do you have a cough?" And they'll say, "No, I don't have a cough." But actually, you later find out that they do bring up phlegm, that they expectorate. And so because we just say, have you got a cough? The patient will go, I don't have a cough because I'm not going all the time. But they are still bringing up phlegm. The Chinese word ke implies cough, and the Chinese word suo implies expectoration. So the language gives us a continuum. And there are quite a few examples of this relevant in Chinese medicine. We've got the urinary dysfunction called long bi in Chinese. Long means dripping and hesitant, and B means obstruction. So this is different. This is a continuum in urinary tract disorders that goes all the way from reduced flow to complete stoppage of urination. But we don't have that word we don't have that convenient concept in English. So the structure of Chinese language is also an important part of practicing it. Another one is bunglo, which is menstrual leaking or abnormal bleeding that's either spotting all the way through to flooding. So this is leaking and flooding, in a sense. But if we say to a woman in the clinic, "Oh, do you have abnormal bleeding?" then they're thinking he's asking if I'm flooding all the time and constantly bleeding. Whereas the Chinese word bunglo gives the patient the choice of going all the way from spotting all the way through to bleeding. So we've got other hindrances to understanding that are linguistic based. So I think we should just beware these smart people who do all the translation. We should just be checking up on them now and again that they're not completely misleading us. So that's the second. The third, of course, is cross-cultural differences. This is what I'm heading for. I'm kind of halfway there now. That we have different experiences around the world, that different cultures will experience dysfunction in different ways, that our experience of health dysfunction is culturally dependent. And the classic one in medical anthropology is Koro, which is endemic across Southeast Asia. It's in China as well, and also in East Africa. And it's where a man imagines that his penis is shrinking. And this is real. I actually saw a case of this. Sorry, it's real in people's heads, so they really believe it. And I actually saw a case of this a couple of years ago for an African guy. The experience of living in a human body and having things go wrong with us is a lot more culturally dependent than we imagine. So Chinese culture from the Han Dynasty isn't necessarily the same as the culture in Godalming in Surrey in the 20th century. A few examples I'll breeze through a few quick examples. Post-traumatic stress disorder was invented 20 or 30 years ago, 20 years ago or so, by the Western counselling and psychotherapy community. It didn't exist as an entity before. People have experienced, for example, the shock of war in the First World War. They used to freeze, didn't they? They used to carry people off from the trenches, frozen, into hospitals kind of like this. And that was the cultural norm for shell shock and for trauma in war. And we've changed that through time. When they had the tsunami in Asia a few years ago, there were plane loads of counsellors and post-traumatic stress disorder experts flew out to countries like Sri Lanka, knowing that with a toolbox for knowing exactly what patients would have, what these people would be suffering, what their experience would be, and how to treat it. And they got there and they found these people were not following the rules. They didn't have the symptom list. They weren't having the nightmares, the dreams, what have you. They were having some stress, but they were experiencing it completely differently. And this was really shocking to the people who went out there. They were really disappointed. They were cross with the Sri Lankans, for example, for not following the rules. It caused enormous difficulty. Actually, what they found was that Sri Lankans, their concern was not about their own personal hardship and their own personal problems. The hardship they experienced was a sadness at the breakdown of their social network, their relationship with other people. The social network had broken down, and that was their experience of dysfunction after the tsunami. They weren't having nightmares. They weren't having flashes of the disaster repeating again like Westerners do. Depression is another interesting one. We've got this whole epidemic of depression in the Western world. And we kind of assume that this is transferable for the rest of the world and also backwards through the whole of history. But when the makers of Seroxat and Prozac got marketing their products around the world, they looked at the sales figures and they were very disappointed with Japan. The sales were really poor in Japan. And so they actually got anthropologists and professors and they convened a conference to go and look into why they weren't selling enough Prozac and Seroxat in Japan. And what they found was that the Japanese people didn't really have depression as such, that they didn't experience it in the same way. If anything, Japanese people experience depression as an opportunity for personal development, for deepening their experience of life and having a deeper understanding of the cycles of life and death and other things. So it was considered to be what's called a jibyo, a personal challenge that is an opportunity to deepen your experience of life. Well, Seroxat and Eli Lilly and SmithKline Beecham didn't like that. So they actually started a campaign in about 2002 to teach the Japanese how to be depressed properly. And they did. The trouble is they had to invent a new word for it, so that in order to medicalize it, in order to medicalize depression and to teach the Japanese how to be depressed, they gave it a new name. They rebranded it, and they called it a cold of the soul. And you can go to the doctor, oh, you've caught a cold of the soul, and the treatment is Prozac or Seroxat. And their sales rocketed. They actually went to a country, taught them how to be depressed. And now, but our assumption is that depression is a real thing, that it's all these people suffer it. Don't take the mickey out of that. It's serious. So people commit suicide and everything. But even things like that are not 100% real. They're culturally dependent. One of my favourite Chinese characters is the character Chou, which kind of illustrates that traditional Oriental understanding of low emotional states that we all suffer from time to time. And this character consists of a picture for a wheat stalk with the character for fire, Huo, and the character that suggests emotion. So this is kind of describing the emotion that you get when you're in the autumn of your life, watching the stubble being burnt in the fields, and you're understanding at a deep emotional level the changes of life cycle, the changes of the seasons, and the fact that your life is getting into an end. So it's a kind of sadness, but it's a philosophical sadness. And this is the sort of words that the Chinese medicine dialogue is made out of, and the emotional dialogue is made of, which is not translated properly by the word depression, although this character is sometimes translated as worry, sometimes translated as depression. So we've got this problem, this cross-cultural problem to worry about. So even physical symptoms can have a cultural slant. As I mentioned before, TB would kill lots of people. And one of the signs of the person dying of TB would be night sweats. One of the signs of somebody dying from the plague would be high fever and sweating profusely. So in traditional Chinese culture, traditional Oriental culture, sweating was a red light going off. It's a warning sign that something is going wrong and that your fluids are leaking out, which is almost tantamount to your blood leaking out in traditional Chinese culture. So, and we don't have that. In our culture, sweating is a sign that you're working out and you're being fit. And it's actually a good thing. Look at me, I'm really sweaty, I'm really working out. So we don't see this as having any negative connotations at all. Sweating, we've lost the cultural sense of sweating as an indicator of disease, in a sense, on the whole. Hang on. I'm supposed to be kind of evidence-based, and I like to kind of think evidence-wise. Is there any actual research to support what you're saying? Because it's all very nice for a man to come up and stand on a podium and spout. But is there anything to support this? Well, in 1987, I was delighted to find a wonderful paper. I sent this to Ted Kapchuk at the time, and he said this was the best paper he'd ever read on Chinese medicine ever. I thought it was really quite good as well. Because you know the way we Westerners have, for the last 100 years or so, gone off around the globe to Sumatra or whatever, looking at fuzzy-wuzzy tribes and taking notes and putting them under the microscope and kind of looking at them and studying foreign peoples. But we don't expect people to come and study us. You know, we don't expect funny foreigners to come and look at us. But in 1987, a bunch of Chinese medical anthropologists went to America to study whether you could do whether Chinese medicine's diagnostic methodologies worked on Westerners. Great idea. What a fantastic idea. And sure enough, they found a lot of things did work. A lot of the questions we asked did match with the patterns that the patients had got, but they found that American patients, even if they've got terrible spleen Qi deficiency, their appetite was unaffected. They'd still eat 4 Big Macs for breakfast or whatever Americans do. They confirmed my suspicion that the appetite question, do you have a good appetite, is not necessarily efficient as a way of gathering meaningful data on Westerners. So they looked at Qi deficient patients, and Americans would not claim that they sweat easily with Qi deficiency. They found that they didn't sweat. So we can kind of at least question that symptom, or re-examine it, or abandon it, or whatever, because some of these symptoms just don't really work on Westerners. They found these Americans would just have cold, chilled drinks, whether they've got a hot body condition or a cold body condition. That's to say their minds, their consciousness wasn't connected in the way that Chinese people are into sensing that having a cold drink was going to have an adverse effect on them. They couldn't sense it, whereas Chinese people can sense it. I had my daughter-in-law who's from Nanjing had a baby while she was living with us, so to speak, in the hospital. Had a baby while she was living with us, and her mother came over from Nanjing, and she wasn't allowed to stand near the fridge. If she wasn't allowed to open the fridge door because of the coldness coming out. And again, we just don't have that. So Chinese people have got an inbuilt sense of hot and cold and what's appropriate to do at any one time. So a Chinese person would shiver within, would then find it absolutely terrible to have a cold drink if you've got a cold condition. They found that Americans were unaware of abnormal tastes in their mouth. They found that 30-something% of yang deficient patients had a bitter taste in the mouth. Those that did report a taste, well, that's completely wrong. Do they not know how to behave? They don't. They're basically not. We are not the same as Chinese people. So, if we just bring this to a conclusion, what does this mean? It means that we do have the problem of truth decay in Chinese medicine. That something is wrong somewhere, which isn't to say that it's all wrong. And I've got, as you know, an enormous respect for the whole tradition. I think it's incredibly powerful. I think that actually we've got less of a problem with truth decay in Chinese medicine than we do in science for various reasons that I won't go into. But we do have to bear in mind the possibility that some of our heartfelt truths, some of the things that we just believe to be true from our training, from our study, from our acceptance of the Chinese medicine tradition, that some of it is going to be wrong. Some of it is certainly wrong. So because of the way things change through time, the way that our medicine was informed by diseases that don't really exist in our patient population, by the way that translation distorts, and also by the way cross-cultural transportation changes things. And actually, some people are beginning to do this. I was really heartened about a year ago to see a wonderful article in the Journal of Chinese Medicine where they actually decided to research one of our heartfelt truths, and that is that eating raw food causes spleen deficiencies. And so they actually took a bunch of people and randomized them, and half of them, they measured their spleen Qi as accurately as they could, and half of them, they had them eat raw food for 6 months, continuously, nothing else. And the other half, they insisted they just had cooked foods, and they then measured their spleen Qis again after 6 months. And actually, the people on the raw food diet had got slightly stronger spleen Qi. So, damn it, why have we been saying to our patients, oh, God, don't eat a cucumber, God, you'll die. And actually, in the Han Dynasty, it was true, because eating raw foods and vegetables that have been grown in soil that have been fertilized with night soil would lead to dysentery. So, yeah, that's a pretty obvious sign of spleen deficiency. So in the Han Dynasty, it was true, and in Surrey, it's not. Or Berkshire, sorry, we're in Berkshire, aren't we? So that's a really interesting thing. So it's wrong today, really, I would say. So what do we do about this? What do we do about this problem? I think really there's two areas. What do we do as practitioners? Because you're not all going to suddenly start researching the truths of Chinese medicine. But at least I think the first issue is awareness of the problem. That if we at least know that we've got to have a question mark, we've got to be suspicious of our truths. We've got to not just accept them in a credulous way, as a kind of, oh, it's from Chinese medicine, it's wonderful, it's historical, it's there, it's in the classics. What was it? I mean, there's some people into cosmology. They're into the study all the ancient pre-Han Dynasty cosmology about the stars and everything, and the belief systems that worked around that. And they get really carried away with it. What if it's bollocks? You know, so somebody said, I went to one of these seminars and they said, the Pleiades, you know, that cluster of very small stars, was viewed by the ancient Chinese as an ejaculation in the sky. Okay, so when I get, when I get a news agent from Moss Side come to me with fertility problems, I'm going to suggest that he stands outside at midnight connecting his Shangxing point on his head with that particular constellation in the sky. No, it probably worked when they invented it first time round because it was part of the culture and they believed it, but it's not necessarily right for us. So we've got to have some awareness of the problem. We've got to have some criticality, I think, in our day-to-day practice, that we should be not just performing our duties as practitioners and using the tradition, but we should actually be just having one or two brain cells in the back of our head that go, actually, can we change this? Can we improve this medicine? And having studied Chinese medicine history quite a bit, I've noticed that the people who contributed most to the development of Chinese medicine were the people who were critical, because throughout history there were critical thinkers who've helped get rid of mythologies and helped improve the medicine. And also the third thing that as a practitioners we can do is find ways of sharing our knowledge. I mean, that's one reason I'm standing here, is to kind of share what my narrative has been in the last 28 years. But we have to find ways of pooling the experiences that we have and talking about about what we've learned, passing it on and stuff in a way. But also there's the question, not only as us as practitioners, but as a profession, what this means to us as a profession. Because I think that in a sense, conventional science and conventional medicine is right to criticize Chinese medicine practice for being backward-looking and stuck in the past, in a sense, because we aren't, I think, sufficiently critical. And so as we mature as a profession in the West, I think that this has to be on our agenda as a profession. My own view is that we have a kind of responsibility to the population at large and to our patients, because we're, in a sense, custodians of what I believe is the most viable complement or alternative to the excesses of modern industrial chemical-based medicine. I personally think that what we've got from China and from the Far East in this medicine is the most powerful, is the most valid, is the most evidence-based alternative to industrial chemical-based medicine and all the things that are going wrong with that. So in a sense, we have a responsibility to, as custodians of this medicine, to be more critical of it and also to improve it and to be the antidote to the ills that are afflicting modern medicine. So that's what I'm saying. So in a sense, we have to be true. We have to be true, we have to be critical, we have to be reflective so that we can improve our medicine. We have to investigate it so that it matches modern practice better. Okay, that's it. Thanks very much. Okay. I thought it was going to go overrun, actually.
So we have got time for some questions. So does anyone have a question on what Charlie said?
Hi, this is
Yes, please.
Hi.
Hi.
I enjoyed that. Thank you very
Thank
much.
you.
I love the open quote. What I was wondering was, because it struck me as well what you've been saying, it's very useful in terms of tongue and pulse diagnosis with modern patients. I looked at an old book at the Welfare Institute once from the 19th century, and there you saw an awful lot of what I learned as an acupuncturist with
Yeah.
infectious diseases. And one second, very quick question. Today we see patients who in the past used to survive because antibiotics didn't exist. So there wasn't that experience of those patients in the past, and what your feelings are towards how we sort of maybe adjust our practice to take that into account.
Okay, two questions then. I think that, did everybody hear that, by the way? Right, question one was, where does what I'm saying leave pulse and tongue diagnosis? And should that be considered under suspicion, or should we just accept that? I think that's question one. And the second question was, another change that's happened through history is that we've now got patients who take antibiotics, and this changes the expression of illness in the modern population as well. Is that kind of what the questions were?
People survive today.
Ah.
In the past wouldn't have done. So the ancients would have seen those tongues and pulses.
Right.
In any,
Now, how do we know that?
well, I think we can be reasonably sure that people who died of infectious disease
Well,
in the West.
the most effective drug for malaria is Qinghao, which is, which is so. And actually, when we look at the Chinese Materia Medica, there are a lot of very powerful antibiotic substances there that were used even for things like septicemia. I don't know what the success rates were, but from the research, from the pharmacology we've got, there's a good chance that they did work. So we might question your assumption there, but I'm not putting you down or anything. I'm not criticising. No. But tongue and pulse diagnosis. Why? I think personally, I believe that almost anything is researchable. We should be able to come up with questions that research questions that help clarify and improve the tradition. I stand firmly in the Chinese medicine camp as an ex-scientist and ex-neurophysiologist. I've got a ghost of me that's still scientific, but the way I view it, in a way you can stand in the science position and you can look to Chinese herbal medicine or you can look to acupuncture and you can say, oh, there's some interesting stuff there, maybe we can nick it, and kind of emasculate this tradition. Or you can stand in the Chinese medicine position and we can say, actually science has got powerful tools to gauge truth. We can nick the tools and still have our minds in the tradition, and that's where I stand. Is that I'm interested in the way that science can actually make traditional Chinese medicine better, not to scientize Chinese medicine. And so we can do. There has been research on tongue diagnosis. There's been a whole load of research on tongue diagnosis. There's no reason, and there has been some research on pulse diagnosis. And there's also, we can invent new research methodologies to look into things that are more experiential, like pulse sensations, what have you. But I'm just saying the general question, let's be critical. Let's actually reinvent Chinese medicine with respect to the past and to have a critical a profession that is growing and maturing with the benefit of modern science and with the benefit of modern clarity of thought. That's what I want to see.
Any more questions?
I just wanted a comment about spleen soup.
Yes.
Now we eat salad and all other vegetables we can eat as raw because we have a system of cleaning tap water, running water.
Yes,
but
yes.
in ancient China, they didn't have that clean water access, as well as the fertilizer they used was human feces, etc. Yes. So there's a lot of bacteria and a lot of parasites they are eating. So I think it's also a different concept of raw food eating.
Yes,
diet.
in a sense, any of the points I've made today, we could actually expand, and it would become more complicated than I've put over, of course. So, for example, I think that if you ate a cucumber, 5 cucumbers a day raw, I think you would get spleen deficiency signs, because I think cucumber really is cold. I think it really does cause loose bowels and what have you. And so, although I say this research, I think that the truth is a lot more complicated than that. Does that answer your question? Sort of. Yeah.
a lot of the people that we see are primary care people, are people with a non-threatening disease,
yes.
rather than are more discomfortable about their health.
Yes.
And it's a very different way in the West that people want to come and see us once a week, or they've got to fit it in with their other. It strikes me that is a great change as well.
Yes. Oh, definitely.
Do you have any comment about that?
I find this enormously. Just in the last 2 weeks or so, I've had a whole load of patients with a need to be seen twice a day even. And it's just not possible for me to do it. So I have to fudge the issue, and I have to kind of not do Chinese medicine in an optimal way because of patient expectation and because of people. One of the biggest problems we've got in doing Chinese medicine is that our patients don't understand where we're coming from. They don't understand anything about Chinese herbal medicine, the way it works. They don't understand pattern diagnosis. They don't understand what it is we're doing. And that creates an enormous difficulty. I had a patient come to me some years ago she's about 55 and she's got menopausal symptoms, and she'd been having acupuncture from the age of 6. I think she saw Felix Mann, originally when she was a child, and she's had acupuncture her whole life. So her presupposition when she came to see me was that she would come to me once every 2 months. But on the other hand, she's walking through the door saying that she's having menopausal hot flushes and it's all terrible. Well, I'd lost the battle there, because I'm saying, I really need you to come at least once a week to start with, or I'm not going to be able to make a difference to this. But she couldn't compute that, because all her life, all her practitioners had told her once every 2 months is enough. So we've got that difficulty, really. When we have Chinese medicine hospitals, and when we're more incorporated into the conventional healthcare pathways, then I think that we'll be able to do Chinese medicine better than we can now.
Yeah, Mike.
Hi.
Thanks. Mike Cummings. I'm one of the knickers.
Yes, I know. Yeah. Yeah.
Thank you. That was a very interesting talk. And you described how there were some areas that quite clearly you would question.
Mm.
What I'm interested in is, how do you invent the new stuff that you need? Have you thought about that?
Because I'm standing in the Chinese medicine camp, we're doing it with our strands of thinking. Basically, we have a set of precepts that go back to the Warring States period, 500 to 400 BC, and that these are the warp threads of our culture, we Chinese. And actually, each generation takes those warp threads and does its own advancement of the fabric of what we do. So actually, from my point of view, that's what I mean in a sense about we can use science as a new approach to taking what we know already, taking the tradition we have already and improving it. And I know that's difficult. It's difficult to compute, because when you learn science, you learn this is truth, and this is a way of accessing truth. So I've kind of stand on both positions, but my loyalty, my heart, is with Chinese stuff. That doesn't really answer your question, does it, Mike?
No, but I've seen you. I've heard you today, and you could publish these ideas if you dare. I'm sure you do. But I haven't, in all my interaction with people, and I've never heard of anything that's new that's been invented. Maybe...
So invented in Chinese medicine?
Well, anything that's very contemporary that said, okay, this was wrong, now we should do it this way.
No, because the Chinese tends, because it would be rude to people of the past to say that's wrong. We just do something else and don't say it's wrong. We just keep it in there because it might be useful. It's like the bottom drawer of a cupboard somewhere where you kind of you've got granny's sheets or whatever. You never know when they might come in useful. And so the Chinese medicine. The Chinese cultural approach is not to revolutionize. In a sense, in modern medicine, you go, oh, it's a new paradigm, it's a paradigm shift, it's a new revolution, we chuck that out, how silly they were. In a sense, Chinese medicine doesn't have that, how silly they were, but we just kind of quietly drop it. Or we think, it might come in useful later, we'll stick it in the bottom drawer. So it's a different cultural approach to the acquisition of truth. And both have their merits, I think, in a way.
Okay, so we've got probably one or maybe two questions. So, yeah, at the back there.
Thank you, Charlie. That was great.
Thank you.
I was really interested in the research on the Americans done by the Chinese
Yes.
anthropologists.
Yes.
The lack of the change in appetite or the sweating, would that have been, in your opinion, because of cultural differences or physiological differences? Was it a study done on Americans of Asian and African
No, this was done
background?
in the ENT department of a hospital in America. So they just took, I can't remember, 500 patients or so and just did a Chinese medicine clinical diagnosis on them all. I
So
think
it wouldn't just have been Caucasian Americans?
it was just a random mix of people coming through a hospital. I can't remember where the hospital was, but I think it was probably predominantly Caucasian Americans, but I'm not sure.
Do you have an opinion or an understanding of why that difference would be?
Basically, food is really important in Chinese culture because there have been recurrent famines, and so they have a cultural memory of death by starvation and death by withering away. And so a Chinese person, if their appetite disappears, in Chinese traditional culture, would at the back of their mind be thinking, I'm going to die. This is actually the down escalator. Whereas Americans don't even think like that. And actually, in modern Western culture, most people, a large number of people, never feel hunger. They never actually have their bodies, they'll never allow their bodies to feel hunger. It's almost as if hunger is viewed as a kind of pain. And so people, the moment they feel slightly peckish, they have snacks, they have cakes, they have biscuits, they have a meal. And so actually you lose touch with the hunger experience. And I think it's actually quite liberating. It's quite a good thing to do. And I sometimes say this to patients, to actually deliberately allow yourself to feel hunger on a regular basis. And because Americans don't really do that, then they lose the neural pathway between the hunger mechanisms and consciousness becomes grassed over, and it's kind of irrelevant. It's like losing your libido or something. It's kind of a loss. You're just no longer able to properly relate to the experience of being hungry. Does that make sense?
Okay. Thank you.
Okay, we're going to have to leave it there, and I'm going to be watching later so we don't snack, but you've got half an hour to have tea or coffee back there. But a final thank you to Charlie.